Hello, my name is Donna Edwards and welcome to Addiction Counselor CEU. Today we're going to continue to discuss the second part of the telehealth treatment for substance use and mental health disorders. Telehealth is the use of a two-way interactive video and/or audio technology to provide health care to individuals experiencing serious mental health illness or substance use disorder. The goal for this presentation is to discuss the evidence for specific telehealth delivered treatments for individuals with SMI, SUD, and co-occurring disorders. While telehealth modalities for SMI or SUD may synchronous real-time or asynchronous, non-urgent communication between clients and provider. The evidence review in this presentation focuses on synchronous interventions to treat SMI or SUD. In addition to treatments via telehealth modalities, in this presentation also provides information on ways programs can provide telehealth delivered services along with the continuum of care for SMI and SUD, which includes screening and assessment, medication management, case management, recovery support, and crisis services. Telehealth is effective across the continuum of care for SMI and SUD, including screening and assessment, treatments including pharmacotherapy, medication management and behavioral therapies, case management, recovery supports, and crisis services. The evidence-based review and rating process. This evidence review, detailed later on, began with an environmental scan to identify treatments for mental disorders and SUD that have been found effective when implemented through telehealth modalities. The first step is to identify treatments that meet the inclusion criteria, have a standardized, replicable implementation protocol, use synchronous telehealth modalities for treatments of SMI or SUD, are currently being implemented in the field following an environmental scan, review of the literature, and consultation with experts. Cognitive behavioral therapy, cognitive processing therapy, prolonged exposure therapy, behavioral activation therapy, and medication-assisted treatments meet the inclusion criteria. The second step is to identify studies that meet the following inclusion criteria, published in or after the year 2010, employ a randomized CAUSAL experimental design, or are a single sample pre-post design or an epidemiological study that analyzes what would have happened in the absence of intervention. Descriptive and implementation studies, meta-analysis, and symptomatic reviews are not included in the review. The third step is to review each study meeting inclusion criteria for strength of study design and statistically significant positive outcomes related to SMI and SUD. For each renewed study, assign a study rating. Many of these telehealth studies examine slightly different questions than most evaluation studies. Typically, an evaluation of the effectiveness of a specific therapeutic practice will assess whether the practice yields better outcomes than a controlled consisting of no treatment or a treatment as usual approach. However, for many telehealth studies, the question posed is whether outcomes for telehealth recipients are comparable for those receiving the therapy in person. Given that telehealth is typically less expensive and easier to access, the question addressed by these studies is one of non-inferiority. Does telehealth delivered evidence-based therapy produce similar and no worse outcomes than evidence-based therapy delivered in person? The fourth step is assign evidence rating for each treatment based on the number of studies demonstrating a high, moderate, casual impact on mental health and substance use outcomes. Let's take a look at this diagram shown here for screening and assessment. We have the treatments, the pharmacotherapy, medication-assisted treatments, medication monitoring, and behavioral therapies, included with case management, SUD recovery supports, and crisis services. Screening and assessment for SMI and SUD are the first steps to effective treatment and can be effectively conducted using asynchronous and asynchronous telehealth modalities. SMI synchronous screenings and assessments for mental disorders conducted via video conferencing modalities have similar reliability and accuracy to in-person screening and assessment. Asynchronous tools that are completed by a client and later reviewed by and discussed with a provider can increase access to screening and assessments when no clinician is available. With SUD, providers can administer screening tools and assess risk of SUD using telehealth. Early evidence suggests that computer-based assessment tools for SUD may increase engagement in the screening process as well as a response to accuracy. However, confirmation and diagnosis of SUD through telehealth has limited evidence. This is largely due to the 2008 Ryan-Haidt Online Pharmacy Consumer Protective Act, which prior to the COVID-19 pandemic required in-person evaluations before providing medication-assisted treatments. Telehealth modalities can be used to connect clients, care teams, and support systems during the creation and implementation of an individualized care plan by increasing the diversity of specialists in terms of clinical specialty and geographical location that can be consulted for diagnosis, assessment, and treatment. Second is engaging an administrative staff via patient portals, clinicals, and providers via electronic health records and video conferencing consultation, and support networks such as friends and families via teleconferencing and social media in various components of treatments. Once a diagnosis is made, clients and providers can determine together the appropriate of various telehealth modalities and identify when telehealth, in-person, or a hybrid approach will be best met the client's treatment goals. Appropriateness of telehealth may depend on several factors, including the nature of complexity of the intervention and the client's condition, client's comfort with technology and telehealth appointments, ease on preferences and assessing in-person service or using technology. Designing and updating the care plan is a collaborative and interactive process between client and provider and involves a conversation on client comfort, preferences, and goals. SMI and SUD treatment, pharmacotherapy, medication-assisted treatments, and medication management can be implemented by using a synchronous of telehealth for SMI. Prescribing and monitoring medication using telehealth can lead to reduction length of hospitalization and symptomology and improve medication adherence. There are also limitations to prescribing and monitoring medication that should be noted, such as evaluating movement disorders and the ability to test muscle tone. Example given, in order to gauge rigidity as a side effect of the medication. Medication-assisted treatment, MAT, uses a pharmacology medications in combination with counseling and behavioral therapies to treat, diagnose SUD. MAT involves multiple components tailored to meet individual clients' needs, including initiating medication, monitoring adherence, and providing access to counseling and psychosocial supports. MAT includes FDA-approved treatments for opiate use disorder using methadone, buprenorphine, and naltrexone, and alcohol use disorder using naltrexone, dysphorium, and acamprostate. Currently, there are no FDA-approved medications to treat stimulants or marijuana use disorders. MAT is regulated by the Drug Enforcement Administration, DEA. Prior to COVID-19 pandemic, practitioners could not provide certain components via telehealth. Due to temporary changes for COVID-19 that may or may not become permanent, there are several models for using a hybrid in-person and telehealth approach to delivering MAT. For example, a physician may perform an initial assessment and prescribe medication via video conference while local clinicians provide counseling and follow-up in person, or a physician could prescribe medication and monitoring during an in-person visit, and the client then receives counseling via telehealth. As a result of changing regulations, evidence for the provision of MAT solely through telehealth modalities is limited. Studies include the review examines multiple components of MAT, some of which are provided via telehealth modalities and others through the hybrid approach, combination of in-person and telehealth approach. Here is a chart of the strong evidence for the medication-assisted treatment using the hybrid telehealth and in-person approach. Medication management via telehealth ranges from automated, nonspecific text message to adherence counseling conducted over the telephone. Examples of telehealth modalities for conducting medication management are described below. The text message interventions designed to remind clients to take their medication have been found to be effective for people experiencing SMI even when the messages were not customized or specific to the diagnosis, timing, or medication prescribed. The smart pill containers remind clients to take their medication, provide alerts about taking the wrong medication, and are linked to programs for the client to report side effects to providers. Used together with telephone support, smart pill containers have shown statistically significant improvements in medication adherence. mHealth apps have been used in combination with smart pill containers, in-home dispensing devices, or other systems dose medications. These apps remind clients to take medications and communicates medication use information their healthcare provider through the client's portal. Treatment support over the phone from case managers, nurses, or other health professionals offer clients prescribed medications for SMI and SUD information and adherence support. These approaches have shown statistically significant improvements on medication adherence rates. Medication monitoring, including both support for medication adherence of the prescribed treatments and prevention of non-prescribed or illicit substance use that may cause dangerous interactions, is an essential component of MAT. Clinics or other agencies without a local trained MAT provider have used telehealth to link clients to a remote MAT provider. The local clinic and agency can provide in-house medication monitoring and urine toxicology screening while providing space for the client to meet with the MAT provider using telehealth technology. In some treatment models, monitoring visits are conducted using telehealth, but the client is required to report in person for regular urine toxicology screening. Behavioral therapies. Practitioners can implement psychotherapy and behavioral therapies through synchronous telehealth modalities while adhering to clinical specifications and producing clinical improvements similar to treatment outcomes from in-person care. This evidence review identified 4 interventions that meet evidence review criteria and improve health outcomes for people experiencing SMI, including behavioral activation therapy, cognitive behavioral therapy, cognitive processing therapy, and prolonged exposure therapy. Each behavioral therapy is described, including associated health outcomes, populations that may benefit, and other important information for implementing these therapies using telehealth. Let's take a look at the behavioral activation therapy via telehealth and the strong evidence. And here we have strong evidence of cognitive behavioral therapy via telehealth. Here is the cognitive processing therapy via telehealth. And we have strong evidence for the prolonged exposure therapy via telehealth. While this review focuses on synchronous interventions, providers can use asynchronous tools to complete, support, and reinforce synchronous client-provider interactions. Examples of asynchronous tools can be found through online repositories such as mHealth Index and Navigation Database or the VA App Store. Ongoing case management may include routine check-ins and follow-ups, updates and modifications to care and treatment plans, identification of and connections with needed resources, and support in achieving the goals of an individualized care plan. These ongoing conversations are readily adopted and synchronous Telehealth Modalities and Health Insurance Portability and Accountability Act (HIPAA) compliant asynchronous messaging platforms, including texting and messaging through a clinic electronic health record (EHR) system. Specific studies have demonstrated ongoing case management interventions using telehealth are effective for people with depression and schizophrenia. Supports practitioners can provide ongoing recovery support for people in SUD treatment through synchronous telehealth methods. Peer recovery support services use peers, people who have similar lived experience as the client, such as someone who is in SUD recovery themselves, to provide support for clients while in treatments and recovery. Some peer recovery support services use technology-assisted peer support to engage clients, conducting regular check-ins over telephone or video conference. Crisis services. Telehealth modalities can increase the availability of needed crisis services, ensuring these services are available to anyone, anywhere, at any time, and that there are no wrong door approach to the entry into services. Crisis services are an effective strategy for suicide prevention and resolving acute mental health and substance use crises, as well as for reducing psychiatric hospital bed overuse, inappropriate use of emergency departments, inappropriate use of law enforcement resources, and the fragmentation of mental health care. Cited by the National Guidelines for Behavioral Health Crisis Care as an essential element of an integrated crisis system, regional crisis call centers provide synchronous telephonic crisis services, text and online sharp technology to triage needs, assess for additional needs and preferences, and coordinate connections for additional post-crisis support. In addition to telephone calls and live online chats or text, regional crisis call centers can make use of the following technologies to support an individual's well-being: 24/7 outpatient scheduling, crisis bed registry, GPS-enabled mobile crisis dispatch, real-time performance outcome dashboards. A synchronous tool such as My Mental Health Crisis Plan, designed by SAMHSA, can be used to create a personal advice directive, a legal document outlining an individual's preference during a mental health crisis should the individual not be able to determine or communicate their own decisions. Suicide screening and assessment. Telehealth modalities provide an effective alternative to in-person suicide screening and assessment. The following suicide screening and assessment tools can be implemented through telehealth modalities. The Ask Suicide Screening Question Toolkit from the National Institute of Mental Health is an evidence-based 20-second, 4-question suicide screening tool. The Collaborative Assessment and Management of Suicidality is an evidence-based intervention to assess, treat, and manage clients with suicidal ideation in a range of clinical settings. Columbia Suicide Severity Rating Scale, also known as the Columbia Protocol, can be used to determine whether someone is at risk for suicide, assesses the severity and immediacy of the risk, and gauge the level of support the person needs. If a client is at risk of imminent harm, first assess for imminent danger. If the client is in imminent danger and the provider is unable to detain or physically intervene, the provider must contact emergency services. Second, identify the client's location in case emergency services are necessary. Then work with the other care providers, such as the suicidal prevention coordinators, when contacting emergency services. Remain connected with the client as the client connects with emergency services or while arranging hospitalization. Then support the clients as they navigate the triage process at an emergency department. Treatment programs should have safety protocols to mitigate risk and create a workflow to support the client. Providers should determine the suicide risk level with the criteria that identify the appropriate clinical response. Here are some future directions. This evidence review supported conclusions related to treatment outcomes. Telehealth is effective across the continuum of care for SMI and SUD, including screening and assessment, treatments including pharmacotherapy, medication management, and behavioral therapies, case management, recovery supports, and crisis services. Evidence-based treatments for SMI and SUDs traditionally provide face-to-face, are also effective when delivered using telehealth and have outcomes comparable to in-person service delivery. Therapeutic services provided using telehealth modalities generate positive outcomes for the client, including engagement in treatment, retention in care, and client satisfaction, which in turn lead to improvement long-term health outcomes.